Welcome to our video on sodium disorders. Let's begin. Here are the topics we're going to discuss in this lecture. Let's start with hyponatremia. We'll discuss definition, causes, clinical features, diagnosis, and management of hyponatremia. Hyponatremia is serum sodium concentration of less than 135 milliequivalents per liter. Let's discuss the causes. First, we have the causes of hyponatremia with low serum osmolality, which is the most commonly encountered. Causes include salt loss, either renal or extrarenal. Examples of renal salt loss are diuretic therapy and primary adrenal insufficiency. Remember that aldosterone increases sodium reabsorption from collecting tubules in the kidney, so aldosterone deficiency in primary adrenal insufficiency will impair this process. Examples of extrarenal salt loss include diarrhea, vomiting, bleeding, third space loss, and burns. In third space losses, there is sequestration of fluid into a third space that is out of the blood circulation, such in settings of severe pancreatitis. Other causes of hyponatremia with low serum osmolality include syndrome of inappropriate ADH secretion, congestive heart failure, cirrhosis, primary polydipsia, and beer potomania. Remember that ADH acts on the renal collecting ducts and increases water permeability and reabsorption. The decreased cardiac output in congestive heart failure and the arterial vasodilation in cirrhosis stimulate the secretion of ADH. This subsequently leads to water retention and hyponatremia. Primary polydipsia is associated with psychosis and characterized by increased thirst and thus water intake, which lowers the serum sodium concentration. Beer potomania is seen in those who drink large amounts of beer, which is associated with decreased dietary solute intake and subsequent reduced water excretion. Okay, let's continue with the causes. Next, we have the causes of hyponatremia with high serum osmolality, which include hyperglycemia, use of mannitol, sorbitol, and radiocontrast agents. In all these conditions, there is water shift from the intracellular to the extracellular space, which lowers the serum sodium levels. Lastly, pseudohyponatremia results from asymptomatic laboratory artifact. It is seen in cases of hyperlipidemia and hyperproteinemia, such as multiple myeloma. The serum osmolality is normal here. Let's try a question. What are the differences between SIADH and primary polydipsia? First, let's remember that antidiuretic hormone is responsible for water reabsorption in the renal collecting ducts, hence concentrating the urine. Now let's compare SIADH with primary polydipsia. In the patient with SIADH, the levels of antidiuretic hormone are abnormally high, which leads to abnormally high urine osmolality and impaired urine dilation. However, in patients with primary polydipsia, the high water intake suppresses the secretion of ADH and results in low or normal antidiuretic hormone levels with low urine osmolality. The urine dilution is intact in primary polydipsia, as opposed to SIADH. In both SIADH and primary polydipsia, the serum osmolality is low, as we previously mentioned. Let's move on to the clinical features. Patient with acute hyponatremia presents early with nausea and malaise. Headache and lethargy may ensue. And when serum sodium becomes less than 115 to 120, seizures and coma can result. On the other hand, presentation of chronic hyponatremia is less severe. Patients may be asymptomatic. If symptomatic, they may present with various and unspecific symptoms such as nausea, dizziness, lethargy, confusion, and muscle cramps. If there is acute exacerbation of sodium loss, seizures and coma may result. Here is an algorithm that we're going to use to elaborate on evaluation of hyponatremia. When hyponatremia is suspected, for example, a patient presents with nausea, dizziness, or lethargy, we need to measure serum sodium concentration. If serum sodium is less than 135 and hyponatremia is confirmed, the next step to identify the cause is measuring serum osmolality. We have three possible results of serum osmolality. If it is high, more than 295, then the possible implicated causes, as we previously discussed, are hyperglycemia, use of mannitol, sorbitol, or radiocontrast agents. If serum osmolality is normal, it is most likely pseudohyponatremia, and the causes may be hyperlipidemia or hyperproteinemia. Now, if serum osmolality is low, less than 275, we further measure urine osmolality. If urine osmolality is low, less than 100, the most likely causes of hyponatremia are primary polydipsia and beer potomania. However, if urine osmolality is more than 100, we evaluate the volume status in our patient. A hypervolemic patient with signs of peripheral edema or ascites most likely has congestive heart failure or cirrhosis. If our patient is euvolemic, the most likely cause of hyponatremia is SIADH. When there are signs of hypovolemia like orthostatic hypotension or dry mucous membranes, we measure urine sodium next to identify the cause. Low urine sodium indicates extrarenal salt loss, for example, diarrhea, vomiting, and burns. High urine sodium indicates renal salt loss, for example, diuretics use or primary adrenal insufficiency. There are a lot of steps. Let's do a quick review. So when serum osmolality is low, but urine osmolality is not low enough, we can evaluate the volumic status. Hypervolemic patients likely have CHF or cirrhosis. Euvolemic patients likely have SIADH, and hypovolemic patients have renal or extrarenal salt loss based on level of urine sodium. Let's try a question. A 30-year-old woman is brought to the emergency department due to tonic-clonic seizure. She was diagnosed with major depressive disorder 5 months ago, and she started taking fluoxetine. Her vital signs are unremarkable. Urine osmolality is high, plasma osmolality is low, and the basic metabolic panel shows hyponatremia. SIADH is suspected. Why does SIADH lead to euvolemic hyponatremia? This woman with a past history of major depressive disorder presents with a tonic-clonic seizure. Urine osmolality is high, plasma osmolality is low, and the basic metabolic panel shows hyponatremia. SIADH is suspected. SIADH is even more likely considering that she takes fluoxetine, an SSRI. Now let's explain why SIADH leads to euvolemic rather than hypervolemic hyponatremia. SIADH is the state of abnormally elevated antidiuretic hormone. Antidiuretic hormone, also known as ADH, leads to free water retention. Water retention in turn suppresses the renin-angiotensin-aldosterone system. Aldosterone normally reabsorbs sodium from the collecting tubule. Therefore, low aldosterone leads to increased urinary sodium excretion along with extra water. Additionally, water retention leads to increased secretion of ANP and BNP from the heart. ANP and BNP both block sodium reabsorption from the collecting tubule, having the same effect as low aldosterone levels. To summarize, SIADH causes euvolemic hyponatremia due to low aldosterone and high ANP and BNP levels. For the initial management of hyponatremia, we need to identify if it is acute or chronic. In acute hyponatremia, which is developed in less than 48 hours, we administer hypertonic saline. In chronic hyponatremia, if there are severe symptoms such as seizures or serum sodium is less than 120, we also need to administer hypertonic saline. On the other hand, if serum sodium is more than 120 in chronic hyponatremia, then limiting water intake and reversing the cause is typically sufficient. Let's finally address some general rules in the management of hyponatremia. Our goal of initial management is increasing serum sodium by 4 to 6 in a 24-hour period. It is extremely important to note that increasing serum sodium should not exceed 8 milliequivalents per liter in a 24-hour period. This is because overcorrection of hyponatremia may lead to osmotic demyelination syndrome. Lastly, in the subsequent management of hyponatremia, fluid restriction is needed in some conditions, like CHF, cirrhosis, SIADH, and primary polydipsia. Let's do a review question. A 46-year-old man is brought to the emergency department due to a tonic-clonic seizure. Basic metabolic panel reveals sodium level of 124. The patient is started on 3% saline solution. 2 days later, he becomes unresponsive. The neurological exam reveals spastic quadriparesis. What best explains the patient's current condition? This patient initially presented with a tonic-clonic seizure, presumably due to hyponatremia. The initial sodium level was 124. The patient is started on 3% saline solution. 2 days later, he becomes unresponsive. The neurological exam reveals spastic quadriparesis. The most likely explanation for this patient's current condition is osmotic demyelination syndrome, previously called central pontine myelinolysis. This likely happened due to rapid sodium overcorrection displacing water from the pontine neurons. Osmotic demyelination syndrome can present with various neurological deficits, including paraparesis, quadriparesis, dysarthria, locked-in syndrome, and coma. To avoid osmotic demyelination syndrome in a hyponatremic patient, the serum sodium level should be corrected by 4 to 6 milliequivalents per liter in the first 24 hours. Next, we'll discuss hypernatremia. We will address the definition, causes, clinical features, diagnosis, and management. Hypernatremia is serum sodium concentration of more than 145. The most common cause of hypernatremia is unreplaced water loss. This happens in both extrarenal and renal loss of water. Renal loss of water is most prominent in patients with diabetes insipidus. Recall that diabetes insipidus is the decreased or absent secretion of ADH, which is known as central DI, or the renal unresponsiveness to ADH, which is known as nephrogenic DI. This results in impaired water reabsorption from the renal collecting ducts and thus massive renal water loss. On the other hand, extrarenal water loss can be due to sweating burns, diarrhea, vomiting, and tachypnea. Note that certain causes like diarrhea and vomiting can be implicated in both hyponatremia and hypernatremia. When water loss is more prominent than sodium loss, we will have hypernatremia, whereas if sodium loss is more prominent than water loss, we'll have hyponatremia. Lastly, iatrogenic sodium overload can be a possible cause of hypernatremia. Clinical features of hypernatremia are mostly nonspecific. Patients may present with altered mental status, weakness, focal neurologic deficits, and seizures. In later stages, coma and irreversible brain damage can occur. We'll use this algorithm to discuss the evaluation of hypernatremia. When the patient is suspected to have hypernatremia, for example, there is altered mental status, we measure serum sodium concentration. If it is normal, we consider other causes. However, if it is more than 145 and hypernatremia is confirmed, the next step to identify the cause is measuring urine osmolality. If it is low, less than 300, then diabetes insipidus is the most likely cause. On the other hand, if urine osmolality is high, more than 600, the causes include iatrogenic sodium overload or, most commonly, extrarenal water loss such as diarrhea and vomiting. Coming to management. If hypernatremia is acute, meaning that it has been present for less than 48 hours, our goal will be restoring normal serum sodium concentration in less than a 24-hour period. This is achieved by administering intravenous 5% dextrose in water at a rate of 3 to 6 milliliters per kilogram per hour, and replacing ongoing free water losses. We should monitor serum sodium and glucose every 1 to 2 hours. When the hypernatremia is chronic, meaning that it is present for more than 48 hours, our goal will be lowering serum sodium concentration by 10 in a 24-hour period. This is achieved by administering intravenous 5% dextrose in water at a rate of 1.35 milliliters per hour times the patient's weight in kilograms, as well as replacing ongoing free water loss. Let's end our lecture with a board-style question. A 55-year-old woman is brought to the ER due to recurrent tonic-clonic seizures for 30 minutes. Her past medical history is non-significant. Her vital signs include a temperature of 36 degrees Celsius, blood pressure of 135/80, heart rate of 89, and respiratory rate of 18. Physical exam is unremarkable. The patient is administered intravenous lorazepam, which aborts the seizures. Her basic metabolic panel is significant for sodium level of 155. Which of the following is the best next step to identify the cause of this patient's condition? A. Urine osmolality. B. Arterial blood gases. C. Complete blood count. D. Water restriction test. This patient presents with recurrent tonic-clonic seizures for 30 minutes. Her vital signs, as well as the physical exam, are unremarkable. The patient's basic metabolic panel is significant for serum sodium of 155, which is high. Therefore, the patient has a hypernatremic seizure. The best next step in the diagnosis of this patient with hypernatremia is to check the urine osmolality. This will help us quickly narrow down the differential diagnosis of this patient's underlying condition. If urine osmolality is high, that it is more than 600, it means ADH is increased. So the patient either has an iatrogenic sodium overload or extrarenal water loss like diarrhea, vomiting, or intensive perspiration. In contrast, if urine osmolality is low, that is less than 300, diabetes insipidus is the most likely underlying cause of hypernatremia. Therefore, the correct answer is option A. Here you see the algorithm of hypernatremia. Pause the video and take a moment to consider this algorithm. Let's discuss why other options are incorrect. Option B and C are incorrect because although arterial blood gases and complete blood count can be ordered in hypernatremic patient, they do not typically help us identify the cause of hypernatremia. Finally, option D is incorrect because although the water restriction test helps us differentiate between the types of diabetes insipidus, we must first order urine osmolality to see if diabetes insipidus is the most likely underlying condition. And that concludes our lecture on sodium disorders.